Welcome to PGOG Pathways to Growth in Obstetrics and Gynecology for Postgraduates and Consultants. And today's topic is fetal growth restriction with a question answer format. How do you define fetal growth restriction? Definition is based on ultrasonography findings. Now, ACOG and RCOG, they are giving slightly different definitions, and that is why I have included the both. ACOG 2021 as given in Williams Obstetrics, it says that estimated fetal weight anytime it is less than 10th percentile for gestational age or abdominal circumference less than 10th percentile for gestational age. That is the definition for the fetal growth restriction, out of which abdominal circumference is slightly more sensitive as compared to estimated fetal weight for the diagnosis of fetal growth restriction. Now, whenever the as per ACOG, whenever the estimated fetal weight is less than third percentile, then it is severe fetal growth restriction, which is usually associated with a compromised fetus. ACOG considers small for gestational age this terminology as a postnatal entity. That means post-delivery baby's weight is less than that expected for that gestational age. Then only it is labeled as small for gestational age as far as American guideline goes. ACOG is American College of Obstetrics and Gynecology. On the other hand, if we see the UK guideline, that is called as Green Top guideline, RCOG, that is the Royal College of Obstetrics and Gynecology from UK, 2024 is the update of that guideline. According to the UK guideline, small for gestational age is the terminology they are using whenever the fetal size is less than 10th percentile. Whereas fetal growth restriction is the terminology which is reserved only if the fetal size is less than third percentile or fetal size is less than 10 percentile with abnormal doppler. That is what has been recommended by the UK guideline. So let us just in short, I will try to write it over here. So what ACOG is giving us is the terminology which is used is fetal growth restriction antenatally, whereas small for gestational age is for postnatally, postpartum after the delivery. On the other hand, RCOG says that small for gestational age are all the fetuses whenever the growth is or estimated fetal weight or fetal size is less than 10 percentile. Whereas fetal growth restriction is only reserved, there are two criteria, less than third percentile or less than 10 plus abnormal doppler. So that is the difference between ACOG RCOG. Another terminology which has been given by RCOG is static growth. What is static growth is when there is no increase in the fetal size by 14 days by ultrasonography. So if you repeat ultrasonography today and it is repeated after 2 weeks and there is no increase in either abdominal circumference or in the estimated fetal weight, then that is another terminology which is used is static. Static fetal growth is there is a plateau which has taken place. Now, another commonly asked question for you can be whether is every fetal growth retarded baby is a compromised baby. So the answer should be it is not like that. Fetal growth restriction It is fetal growth restriction is the new terminology instead of intrauterine growth restriction. And the one with which we passed our post graduation, that was intrauterine growth retardation, which was giving a very wrong concept about the mental retardation, and that is why retardation terminology was replaced by restriction as intrauterine growth restriction. And now the terminology, latest terminology which is being used is fetal growth restriction. So whether every diagnosed pregnancy where there is a fetal growth restriction, whether every baby is compromised. So it is not like that every baby is not compromised. FGR includes constitutionally small healthy fetuses also, as well as it includes growth restricted compromised fetuses, and it is difficult to differentiate between these two antenatally is the important concept. That antenatally, there are certain indications. If the doppler is abnormal, we consider that there must be a compromised baby, but still always it is not possible to differentiate between whether the baby is constitutionally small or whether it is compromised. So depending on abdominal circumference or estimated fetal weight, we do diagnose fetal growth restriction. As far as ACOG goes, anytime less than 10th percentile is fetal growth restriction, whereas by RCOG, less than 3rd percentile or less than 10th along with abnormal Doppler. So there are two possibilities. Either baby is absolutely fine. Constitutionally small means it will be not having any problem. So that RCOG is considers as small for gestational age. Whereas compromised babies, RCOG is only trying to segregate these constitutionally small and compromised fetuses by the terminology. RCOG is using small for gestational age for the fetuses where the this fetal growth, this lag is between uh, 3rd to 9th percentile, or where the lag is less than 10th and umbilical, or all the Doppler, fetal Doppler is studies are normal. That is small for gestational age for the RCOG. Whereas all the rest will be most of the time these will be compromised, and there only they are using the terminology as fetal growth restriction. So if you are asked in examination the definition of fetal growth restriction, it is better to quote both, that according to American guideline it is less than 10th percentile of abdominal circumference or estimated fetal weight, whereas for by RCOG, fetal growth restriction is only if it is less than 3rd percentile or if less than 10th with abnormal Doppler studies. Otherwise, whenever it is normal Doppler study and less than 10th, it is called as small for gestational age as far as UK guideline goes or RCOG guideline goes. Now, can we classify fetal growth restriction, or if you are asked the question, can you divide the cases of fetal growth restriction, or can we classify? There are two ways we can classify. One is on the basis of onset. Early onset is whenever there is an onset of fetal growth restriction before 32 weeks, and late onset is whenever it is greater than or equal to 32 weeks. Depending on cause also we can classify. One is constitutionally small or healthy babies, as I said earlier. That will be one group. Second group will be whenever there will be a fetal growth restriction which is of non-placental cause. Mostly there will be a problem in the fetus, such as there can be a chromosomal abnormality, congenital malformation. In these cases, the placenta is normal, and that is why that comes under non-placental causes. Whereas their third group will be when there is a problem with the placental perfusion, there is chronic placental insufficiency with underlying many different disorders during pregnancy, and that placental causes are placental causes is the third category responsible for fetal growth restriction. So these are the two ways we can classify the cases. How do you diagnose fetal growth restriction? Diagnosis most important is it depends on accurate calculation of gestational age, because whenever we say that fetal size is less than 10 percentile or third percentile for that gestational age. So again and again we are using the terminology gestational age, and that is why the first step in the diagnosis of fetal growth restriction is accurate calculation of gestational age for that given pregnancy. Clinically, we do try to assess the given patient for the presence or absence of fetal growth restriction. By we how we do the clinical assessment is we measure symphysis pubis, superior border of symphysis pubis to the fundus, symphysiofundal height in centimeters, and this symphysiofundal height is equal to gestational age in weeks after 20 weeks of pregnancy. Anytime there is a lag in that symphysiofundal height is less by greater than or equal to 3 centimeters compared to gestational age, that is suggestive of fetal growth restriction. That means if we expect that pregnancy is 28 weeks, we expect symphysiofundal height 28 weeks is pregnancy, we expect symphysiofundal height to be 28 centimeters. In that case, instead of 28 centimeters, say it is 24 centimeters. So the lag is greater than 3 centimeters, then it is suggestive of fetal growth restriction. So this is clinical assessment with that example. And for confirmation, we have to do ultrasonography. We have to we can diagnose it on the basis of single ultrasonography if our dating is good, or there is a we are able to do the accurate calculation of gestational age. But whenever there is a sub patient has got a suboptimal dating, in that case we have to repeat ultrasonography after 1 or 2 weeks. With serial ultrasonography only we will be able to diagnose fetal growth restriction whenever there is a doubt about the dating. And terminology for these cases, rather than calling it as poor dates, it is better to use the correct terminology as suboptimal dating as given in our Williams obstetrics. So correct terminology use is also very important. That whenever you have a patient who where there is a doubt about the uh, gestational age, the terminology you should be using is suboptimal. Patient has got suboptimal dating. If you are asked what is the screening method for FGR, only screening method for fetal growth restriction is measurement of symphysiofundal height, where you measure the symphysiofundal height after 24 weeks of pregnancy. Is ultrasonography a screening method for fetal growth restriction? So your answer for that should be routine third trimester ultrasonography is not recommended for fetal growth restriction screening in low risk population. It is not because it does not improve outcome. What is the technique of measuring the symphysiofundal height? Bladder should be empty. Legs are extended as superior border of this pubic symphysis keeps on changing depending on the degree of hip flexion. That is why it is better to uh, ask the patient to extend the lower extremities whenever we want to measure the symphysiofundal height. Height of a centralized uterus is marked with a pen. Distance from it to the superior border of pubic symphysis is measured by tape measure. And this symphysiofundal height measurement should be a part of routine antenatal checkup after 24 weeks. So first is at 28 weeks we should be measuring it, and later on after whenever patient is coming for the subsequent antenatal visit it should be done. And it is the best method and only screening method for fetal growth restriction, where as we have already seen in the last slide, anytime the lag is greater than 3 centimeters, then it is suggestive of fetal growth restriction. Then it will be an indication to proceed with ultrasonography. Now, how do you assess gestational age? That is almost, I think, any obstetric case you get in the examination, obstetric patient, this question will come somewhere or the other. That what are the various ways of calculating the gestational age? So various methods are by menstrual history, which depends on certainty of date of last menstrual period. By Negley's formula, as we all know, first day of last menstrual period minus 3 months, and then you add 7 days. That gives you expected date of delivery, which we consider as 40 weeks or 280 days, and accordingly we calculate the gestational age in weeks in third trimester by going retrospectively from this expected date of delivery. How do you calculate gestational age in IVF pregnancy? In IVF pregnancies, embryo transfer plus 266 days, because we consider that for the normally also the implantation is usually taking place after the after ovulation. After 14 days there will be this fertilization and then implantation, and that is why we have to add only 260 days, 66 days here. Whenever the 3 days frozen embryo is getting transferred, then on from that day we have to add 263 days for calculation of expected date of delivery. So one is by menstrual history, other is by ultrasonography, where early ultrasonography is better than the sonography which is done in late pregnancy for calculation of gestational age or assessment of gestational age. Now, if ultrasonography is not available, then the date of last menstrual period, if patient is certain about that, along with that careful uterine size clinical examination in the first trimester is said to be in the expert hands is said to be a reliable way of assessment of gestational age. But overall, if you are asked which is the best method, then we have to take help of both by on the basis of date of last menstrual period and ultrasonography. Whenever ultrasonography is done at a gestational age less than 22 weeks. So this gives us a best assessment of correct gestational age in a given patient. Now, how does ultrasonography help for gestational age assessment? How you take the help of ultrasonography and assess the gestational age? If that is the question which is asked to you, then gestational sac measurement in the very early pregnancy, what is seen is only a G-sac, gestational sac, but measurement of that gestational sac is not useful for calculation of gestational age. We need embryo or we need fetus. Measurement of embryo or a fetus is needed for calculation of gestational age. Ultrasonography measurement is used if patient is not certain of her date of last menstrual period or date of last menstrual period is unknown, such as conception taking place during lactational amenorrhea. These are the situations where the Negley's formula will not be helping us, and these are the cases where ultrasonography will be of help. Ultrasonographic method for calculation of gestational age is also used if there is a discrepancy with the LMP, which is discrepancy is greater than the threshold value for that gestational age. Discrepancy is between gestational age calculated by LMP and gestational age calculated by ultrasonography, and that discrepancy, if it is greater than the threshold value for that gestational age, then we have to rely on ultrasonography method for calculation of gestational age. So what is the discrepancy threshold for gestational age calculation by ultrasonography? And when do you label a pregnancy as suboptimally dated pregnancy? Suppose now when in examination, remember that whenever you use any terminology, you are yourself guiding the your practical examination why in that direction. Suppose you say that there are some pregnancies which are suboptimally dated, it will be expected that you should know about that. So suboptimally dated pregnancies are where the first ultrasonography is done beyond 22 weeks, at or more than 22 weeks of pregnancy. These are the all the pregnancies wherever first ultrasonography has been done at a gestational age greater than or equal to 22 weeks are suboptimally dated pregnancy. Where for diagnosis of this fetal growth restriction, we need to do a repeat ultrasonography after 3 to 4 weeks, see for interval growth, and then only we can confirm the diagnosis. Single ultrasonography will not be helpful in these pregnancies. Gestational age by ultrasonography, if there is a discrepancy is greater than threshold, then we use, as we have seen last slide, if you calculate the gestational age by LMP and then use calculate the gestational age by the ultrasonography, and there is a difference and the difference is greater than the threshold, then we have to rely on ultrasonography method. So what is the threshold? What is the threshold? So we start at the lowest, we start at 9 weeks, and then gradually we go upward. So at 9 weeks, discrepancy is minimum, it is 5 days. Whereas at 10 greater than 9 weeks, that is 10 to less than 16 weeks, 10 to 16 weeks, it is 7 days or 1 week. This is most important. That is why I have learned, and I hope that you also, all of you, draw this diagram and learn this, because this is helpful in our clinical practice also. It is the most important in your examination also. This will give you the idea when to go by ultrasonography dating and when to go by clinical dating. Now 16 to 22 weeks, it is discrepancy threshold is 10 days. That means discrepancy greater than 5 days, you rely on ultrasonography. Greater than 7 days, you rely on, or greater than 1 week. And from 10 to 16 weeks, then you rely on ultrasonography. Greater than 10 days, you have to rely on ultrasonography. Here it is greater than 14, easy to remember, and greater than 21 days. So after 28 weeks, it is greater than 21 days. 22 to 28 weeks, it is greater than 14 days, that is 2 weeks. And here it is 3 weeks. So it is easy, 5, 7, 10, 14, 21. Remember these gestational ages also. Less than 9 weeks is the best time to assess the gestational age, because the discrepancy, the accuracy is more, and discrepancy of just greater than 5 days is also an indication to rely on ultrasonography for calculation of gestational age. This is by ACOG 2019, this threshold values, and this is standard, and you should be using it in all the obstetric cases as consultants, or even postgraduate students, as well as you should be using it in examination also if you are given ultrasonography report. Greater than 14 weeks, how we on the what basis we are calculating the gestational age? What we are measuring is the BPD, biparietal diameter, head circumference, abdominal circumference, as well as femoral length. Whereas up to 14 weeks, what we are using is the crown rump length. Our next question is, which is the best ultrasonography parameter to measure gestational age? If you are asked, out of all these, we have seen so many ways of what we measure. Which is the best? Your answer is crown rump length. By transvaginal sonography, preferably, it is better, or your accuracy is more by transvaginal as compared to abdominal sonography. Now, crown rump length is measured from 6 weeks to 14 weeks of pregnancy. It is taken when fetus is in a neutral or extended position. It is taken 3 times, and average of three measurements is taken for better accuracy. Correct crown rump length is the most sensitive parameter to calculate gestational age. Now, why we have seen about the gestational age and ways of calculating gestational age. Next question is, why fetal growth restriction develops? What is the pathophysiology which is considered for the fetal growth restriction? So for that, there are two theories. One is a vascular theory and other is a immunological theory. As per vascular theory, there is abnormal trophoblastic invasion. As we have already seen for the hypertensive disorders in pregnancy, especially preeclampsia, and for the fetal Doppler also we have seen what is happening. So for whenever there is a abnormal placentation by with the abnormal trophoblastic invasion, then this is the vascular theory, that because of abnormal trophoblastic invasion, there is a development of fetal growth restriction. Second is immunological theory, because there are so many immunological conditions or disorders where fetal growth restriction is very common, and it is based on the this theory that there is a rejection of paternal component of fetal tissue, and because of this rejection, maternal rejection, there is a fetal growth restriction. So in short, you can tell that it is pathophysiology or the basis of development of fetal growth restriction. There are two theories. One is a where there is a placental uh, underlying placental problem with the vascular theory, or there can be a immunological problem where there is a rejection of paternal component of fetal tissue. Now, what are the risk factors of fetal growth restriction? In which cases you will consider that there will be an increased risk of development of fetal growth restriction, and for that there is a very long list, and I have tried to divide it. It has already been divided in Williams, and I have tried to make it pictorial for you, as these are maternal, fetal, and placental. These are the three factors. Now, let us see first maternal factors, that whenever there is a less weight gain in pregnancy, less than expected weight, maternal weight gain, maternal small stature, constitutionally small mother, poor nutrition, social deprivation, eating disorders in the mother, all these are the risk factors for development of fetal growth restriction. Now, there are certain factors which are common for both maternal and the fetal, that factors which are affecting mother as well as fetus, such as certain drugs, especially chemotherapy drugs for the malignancy, or certain teratogens taken by the mother will be affecting the fetal growth, leading to fetal growth restriction. Certain infections are there which affect mother, fetus as well as placenta, all three, and that also leads to fetal growth restriction. Maternal medical disorders are affecting mother and placenta, placental perfusion, and that is why it is common for this. Now, for the fetal, what are the fetal factors? Mainly fetal malformations, in which at the top we have this gastroschiasis, which is a very quite common with a fetal growth restriction. Second is congenital heart diseases. Whereas genetic abnormalities in the fetus also lead to fetal growth restriction, all trisomies and Turner syndrome. Now, genetic abnormalities are given as common factor affecting the fetus as well as placenta. So, in placenta, there is a confined placental mosaicism, which is associated with this fetal growth restriction. So, what is happening with mosaicism? As you know, there are two cell lines, but this mosaicism is only restricted to placenta here. That is why it is called as confined placental mosaicism, where the placental tissue, when it is sent for genetic testing, it will be showing the mosaicism, which is a risk factor for development of fetal growth restriction. In multifetal gestation, where there is a especially if it is affects the fetal growth, as well as if it is a monochorionic type of multifetal gestation, and there is twin to twin transfusion syndrome, all sorts of problems are there in that. So it is common for affecting the placenta as well as the fetus. Genetic abnormalities and multifetal gestation affects both, whereas only fetal causes or risk factors are malformations and these congenital genetic abnormalities such as trisomies and Turner, whereas infections will be affecting mother, fetus as well as placenta, viral infection, bacterial infection, especially tuberculosis. Coming to placental causes, placental or cord abnormalities is a risk factor for development of fetal growth restriction. Here, the common is for maternal causes and placental, such as hypertensive disorders in pregnancy, especially whenever there is a superimposed preeclampsia, antiphospholipid syndrome, diabetes mellitus, pre-gestational diabetes, then chronic kidney disease, sickle cell disease. Anemia as such is not such a great risk factor, but sickle cell disease is definitely a risk factor for fetal growth restriction. And ischemic heart disease is emerging as a risk factor for fetal growth restriction, with more and more women opting for pregnancy at a later age. So this is at a glance that we divide the risk factors in maternal, fetal, and placental. There are certain factors which are only related for the matter affecting the mother. Some factors common for mother and fetus both, Some factors are affecting all mother, fetus, and placenta, mainly the infection. And maternal and placental involvement is there in the maternal medical conditions. Whereas placental, you can remember that mainly cord abnormalities and placental abnormalities are it is a risk factor for development of fetal growth restriction. So if you divide and remember or draw it 2 3 times like this, I think students can remember the important risk factors for fetal growth restriction. Now, what is the connection between there is a emerging evidence that these biochemical markers of aneuploidy screening and fetal growth restriction, there is some relationship. So you can be asked that what is the current opinion? What do you think? What is the relationship between biochemical markers of aneuploidy screening and fetal growth restriction? So it is an incidental finding of aneuploidy screening. These biochemical markers are not recommended for routine fetal growth restriction screening. That is first concept which is important, that there is still no evidence that we should be using these aneuploidy screening biochemical markers for the screening for fetal growth restriction. It is an incidental finding. Whenever we are sending this for aneuploidy screening and if there is abnormality, then it can be taken as a uh, high risk factor for fetal growth restriction. So probable risk factors for fetal growth restriction, because these are indicative of placental abnormality as per RCOG 2024, is if there is a fall in pregnancy associated plasma protein A level, or there is raise alpha fetoprotein or raise inhibin level. These three you remember. Whereas SCG has no correlation found with the risk for fetal growth restriction. PA, alpha fetoprotein and inhibin. PA lower level and raise level of these two, alpha fetoprotein inhibin. So that is by some there is still not a strong evidence at present. Enough studies are not there, but it has been observed that as an incidental finding that whenever there is this change, there is a possibility of having a greater risk for development of fetal growth restriction. So whether we should be giving aspirin to this group of women is still a question mark, because enough studies are not there. It is not recommended at present to start aspirin for these women. On the other hand, careful monitoring is indicated, and especially whenever we get first trimester or second trimester and aneuploidy screening, and we get these findings that the PPA is lower than normal, or alpha fetoprotein and inhibin are greater than normal, then it is an indication to go ahead with uterine artery Doppler at 20 to 24 weeks, because uterine artery Doppler abnormality, pulsatility index of uterine artery, that is also one of the indicator for development of early onset fetal growth restriction. Early onset is whenever it is developing at a gestational age less than 32 weeks, where the prognosis is poor as compared to late onset fetal growth restriction. So what is indicated is, if we get normal biochemical markers for aneuploidy screening, it is an indication to proceed with uterine artery Doppler study at 20 weeks to 24 weeks of pregnancy. Next question is, how will you manage a case of fetal growth restriction? That is, you get a long case in practical examination, or sometimes you get a long answer question also in theory paper, where this might be asked. How do you manage? So management is under these principles. The first is, whenever you get a case of FGR, and especially if it is a early onset FGR of less than 32 weeks, it is an indication to search for underlying cause, such as whether there is congenital malformation, whether there is a possibility of chromosomal abnormality, or whether there are what can be the whether it is because of a placental cause, or whether there is a infection which is affecting. So all these search for the underlying cause is the first step. Umbilical artery Doppler is the most important investigation. It is the most crucial investigation which helps us in management of FGR. If you are asked if there is only single investigation you can do, which one you will select, or which is the investigation of choice? Answer to all these questions is umbilical artery Doppler. Umbilical artery Doppler and amniotic fluid assessment help us in management, but out of this, most important is umbilical artery Doppler velocimetry. Fetal surveillance also helps us in management, antepartum fetal well-being or antepartum fetal surveillance by non-stress tests as a screening test. And if it is inconclusive, then we have to go for biophysical profile. And most important component of the principles of management of FGR is timely termination. The reason is if we terminate too early, there will be prematurity, and prematurity induced complications will increase the perinatal mortality rate. But if we wait too late, we are always facing a risk of fetal death or intrauterine death. So we have to strike a balance between these two scenarios, and that is the reason why timely termination is the most important component in the management of fetal growth restriction. Now, why umbilical artery Doppler is most important investigation in FGR, or if you are asked, describe in short about umbilical artery Doppler. Umbilical artery Doppler is the first investigation to show abnormality in fetal growth restriction, which is of placental origin or which is because of placental dysfunction. Two umbilical arteries are branches of internal iliac arteries, and they carry deoxygenated blood from fetus to the placenta. Unique feature is there is a continuous forward flow normally throughout the cardiac cycle in these umbilical arteries. So as you can see here, blue are the umbilical arteries and red is the umbilical vein. Umbilical arteries are carrying deoxygenated blood. That is why I have selected blue color. Two umbilical arteries carrying deoxygenated blood from fetus to placenta, whereas once it gets oxygenated, it is being carried by this umbilical vein from placenta to the fetus. Now, diastolic flow increases with advancing gestational age in umbilical arteries. Diastolic flow increases, and there are two reasons. First is there is a reduction in placental impedance or placental this resistance as the gestational age increases in a normal antenatal woman. Second is there is increase in fetal cardiac output, so that there is a increased blood flow velocimetry during diastole in a normal pregnancy as the gestational age advances. This end diastolic flow is lesser at fetal end as compared to the placental end of the umbilical cord. Umbilical artery Doppler is done usually in a free loop of cord, but whenever there are abnormal results, then fetal end is preferred as it will give a more sensitive uh, it will be sensitive for any change in the umbilical artery flow velocimetry. What we are doing in Doppler is we are measuring the blood flow velocimetry. It is advisable for the students to go through the video of fetal Doppler, where in greater detail I have talked about the principles of Doppler and various types of Doppler, fetal Doppler, which will help you a lot in understanding whatever we are talking right now. Now, this is systolic and diastolic and ratio of systolic velocity and this end diastolic velocity. This is diastole. End diastolic velocity gives us the SD ratio. This is normal. Whenever there is an increase in SD ratio, there is a decrease flow velocimetry during diastole. As you can see, appreciate here, this as compared to this, here there is a reduction in blood flow velocimetry during diastole, so that it increase in the SD ratio whenever there is a fetal growth restriction. Absent diastolic flow, there is no waveform, or reverse diastolic flow are the worrisome umbilical artery fetal Doppler changes. AREDV is absent or reversed in diastolic velocimetry, which are indicative of a very great placental dysfunction, where greater than 70% of the placental vessels are affected by the disease. Now, how will you manage a case of fetal growth restriction if umbilical artery Doppler is normal? Now, by definition, as we have already seen initially only, by RCOG guideline, umbilical artery Doppler normal, and with that, if there is a this percentile of the fetal estimated fetal weight is less than 10th, but greater than third percentile, then in that case it is considered as small for gestational age. But whenever umbilical artery Doppler flow is abnormal, then it is fetal growth restriction. But here we are using the terminology as per American guideline. So how will you manage a case of FGR if umbilical artery Doppler is normal? Means here it is estimated weight is less than 10th percentile, but umbilical artery Doppler is normal. So in these cases, careful monitoring is necessary. We have to repeat umbilical artery Doppler every week. Fetal surveillance by non-stress test biophysical profile also should be done on a weekly basis. Fetal growth monitoring is indicated every 3 weeks. This is important because if it is done earlier, it is not useful. It is inconclusive. That is why we need to monitor or do ultrasonography to see the interval growth. For that, we need at least 3 weeks gap in between the subsequent serial ultrasonographies. Termination is done as per estimated fetal weight and amniotic fluid assessment. Estimated fetal weight if it is between third and ninth percentile and everything else is normal, such as umbilical artery Doppler is normal, with that NST, BPP is also normal on weekly basis. Then we can continue the pregnancy, take pregnancy till 38 to 39 weeks, and we need to deliver. Delivery is indicated by 38 to 39 weeks. With that, if there is a presence of reduction in amniotic fluid, oligohydramnios, then termination is indicated 1 week earlier, 36 to 37 weeks. But if it is a severe fetal growth restriction, where the estimated fetal weight is less than third percentile, these are the babies who are at greater risk for the increased perinatal morbidity, mortality. And even if umbilical artery Doppler is normal, even if NST BPP is normal, still termination is indicated by 37 weeks of pregnancy in these babies, very small, severely fetal growth restricted fetuses. Now, if umbilical artery Doppler is abnormal, then what is the management? So many times we do get patients who are coming with ultrasonography report which shows umbilical artery Doppler either as a absent end diastolic flow or reverse end diastolic flow, and usually that leads to a panic situation. But remember that absent end diastolic flow in the umbilical artery Doppler is associated with a stillbirth rate of 7%, whereas reversed is associated with there is a slight increase to 19%. But as high as 80% will not be going for intrauterine death. Here, as high as more than 90% will remain, will not be having a risk of intrauterine fetal death. So, majority are not going for fetal death, but still we need to be cautious. That is the message from these percentages I wanted to give to you. That means it is not if you get absent end diastolic flow, reverse end diastolic flow, it is not an indication for emergency cesarean section immediately. That is the take home message, provided NST biophysical profile is normal. We have to give an option of hospitalization with absent end diastolic flow, but hospitalization is mandatory with reversed end diastolic flow, as this is a more severe uh, affection of the reduction in placental perfusion, or it indicates a greater degree of fetal affection as compared to absent. Reverse is associated with a poor prognosis, and that is why hospitalization is mandatory. For both the situations, steroid is to be given for to improve the fetal lung maturity. Non-stress test is done 1 to 2 times per day whenever patient is in hospital. But if patient is not in hospital, then at least 1 to 2 times per week it should be done. Fetal growth assessment every 3 weeks, as it is useful only at that interval. Repeat umbilical artery Doppler 2 to 3 times per week is to be done in both the situations. Almost alternate day we need to keep on repeating umbilical artery Doppler velocimetry. Termination with the absent end diastolic flow is indicated by 33 to 34 weeks, whereas it is earlier 30 to 32 weeks whenever it is a reverse end diastolic flow. So especially if it is a early onset fetal growth restriction, severe degree of fetal growth restriction, there is a static growth, these are the situations where if with that there is a reverse end diastolic flow, but NST is reactive, non-stress test is reactive. These are the cases where we continue it till the baby is salvageable. That means up to 30 to 32 weeks, and then termination is indicated. But we have to remember that always we have to strike a balance between the complications because of prematurity leading to mortality or intrauterine death or stillbirth. Now, how do you interpret non-stress test and biophysical profile? Now, remember that obstetrics is very much interlinked. Whenever, if you get a case of fetal growth restriction in practical examination, the questions will not be limited only to fetal growth restriction. There are so many interrelated topics which along which the discussion will go and along which the questions will be asked, and that is why I'm specifically deliberately including these questions, that it is a real scenario where you are dealing with a patient, then also you should know how to interpret in clinical practice, as well as exam point of view. You should know that these questions are most likely to be asked in this case of fetal growth restriction. Non-stress test is a screening test. Two accelerations in 20 minutes is reactive test, irrespective of whether there is a fetal movement or not. But usually with the fetal movements, if there is fetal heart rate acceleration, that is indicative of a greater assurance about the fetal well-being. So it is a screening test for the fetal well-being which gives us idea about the fetal condition. Non-stress test. Now, by whenever we are doing it greater than 32 weeks, then there has to be an acceleration of 15 bits lasting for more than 15 bits, more than or equal to, lasting for greater than or equal to 15 seconds. So there will be a acceleration and it will be of greater than 15 bits lasting for greater than 15 seconds. So that is how we can remember 15 by 15. Whereas less than or equal to 32 weeks, it should be greater than equal to 10 bits and lasting for 10, greater than or equal to 10 seconds. So it will be less than 32 weeks. Don't apply the same. It is 10 by 10. So here also rise is of 10, lasting also greater than 10 seconds. That is, if it is there, then we call it as a reactive test. Reactive is indicates that. Now, if there are no accelerations, we need to keep on repeating the test and continue the test for at least 40 minutes, and some guidelines are even advising it to continue for 60 to 80 minutes. But then in that case, inconclusive, we have to then baby might be in there can be a slip pattern, and that is why non-reactive test is not definite indication for immediate termination of pregnancy. We need to go for biophysical profile. If it is a non-reactive test, there are two accelerations are not observed in 20 minutes, then we need to go for that. Now we come to biophysical profile. In the biophysical profile, there are 5 parameters. First is most important is this amniotic fluid index or amniotic fluid assessment, which can be done by deepest vertical pocket. How much is the measurement of deepest vertical pocket? Second component is fetal heart rate acceleration with movement. That means NST is a part of that. Third is, these are the lungs. So fetal breathing movements. Fourth is fetal tone. And last is fetal body movements. Now for each parameter, there is a score of 2, 2 for each. So maximum score will be 5 parameters are there, it will be 10. Anytime it is, score will be, if it is score of 8 to 10, normal. 2 or 4, abnormal. 6, equivocal. So that is how we interpret biophysical profile. Now there is modified biophysical profile where what we see is only this amniotic fluid at non-stresses, where amniotic fluid only difference is it is by amniotic fluid index, remember. Whereas here we are seeing deep vertical pocket. Here it is by AFI, amniotic fluid index, and NST. These are the two parameters in modified biophysical profile, which is a quicker way and it has same sensitivity specificity as the 5 parameters complete biophysical profile. So this much minimum we should know whenever we utter a terminology anytime in practical examination or in theory also whenever we are writing, this minimum we should be explaining. Now how do you measure amniotic fluid volume? So there are two ways, as amniotic fluid index, or this is uterus, or deep vertical pocket. So what we do is, from linea nigra, vertical line is there imaginary, and from this umbilicus, horizontal line. So that we have how many quadrants? 4 quadrants we have. In each quadrant, we take the largest pocket of the amniotic fluid, which is not containing any fetal part or cord, umbilical cord. And we measure the antero-posterior diameter of each pocket, AP diameter. We are measuring antero-posterior diameter of the longest pocket, like that. And we have to add this plus this plus this and this also. So like that we need to add all these 4 values together, and then we have to add it, and if that value is less than 5, it is indicative of oligohydramnios. Second method is we just search which one is the deepest vertical pocket and measure it. And if it is, this is a better way of assessing the amniotic fluid. Amniotic fluid index is associated with more of false positives. And that is why deep vertical pocket measurement, deepest vertical pocket measurement is, many guidelines are recommending this as a method for assessing the amniotic fluid. And if it is anytime less than 2 centimeters, it is suggestive of oligohydramnios. So this you should always be able to explain, because in any of your obstetric case, you are likely to ask this question. Next is, what is the place of other vessel Doppler study apart from umbilical artery Doppler in the management of fetal growth restriction? So your answer is others are not of much help in the management of fetal growth restriction. The reason is, whenever there is a ductus venous abnormality, umbilical vein abnormality, such as there is a pulsatile flow waveform in umbilical vein, that is indicative of a baby which is having a severe hypoxia. So it is a very late feature. By the time these features appear, almost there is a irreversible neurological damage to the fetus, and that is why these are not going to help us much in the timely termination. It is not a timely termination. If you get a patient who is unbooked patient, she comes to you for the first time and there is a severe fetal growth restriction and you advise fetal doppler and that shows that there is a ductus venosus abnormality, you need to explain that the chances of this good perinatal outcome are less in this case. It is a bad prognostic feature. It indicates that already baby is having severe hypoxia. Already there might be damage to the mainly neurological damage will be there in the baby, and so good outcome is less likely. That is why these are of less help. This cerebroplacental ratio, which is usually done in these babies, it is the ratio of this middle cerebral artery pulsatility index divided by this umbilical artery pulsatility index. More and more brain sparing effect is initially there whenever there is a um, fetal growth restriction, so that initially there is an increase in middle cerebral artery blood flow, but with the increasing severity of fetal growth restriction, the middle cerebral artery blood flow also reduces. That is what is happening. Initially is increase and then there is a fall, and that is how there is a change in this CPR, cerebroplacental ratio. So if cerebroplacental ratio is going less than 1, that is indicative of a that is suggestive of a baby getting affected, but it has got a questionable place because it is not studies have not shown its utility in improving the perinatal outcome. So tools to manage fetal growth restriction, if you see in detail, I have given a star to this umbilical artery Doppler. Most important, most precious, most useful. Amniotic fluid assessment also helps us in management. Non-stress tests, biophysical profile do help us. Estimated fetal weight, as I said, repeat ultrasonography every 3 weeks. That is also because if it is a static fetal growth, there is no increase. That is also suggestive of a bad outcome. But ductus venosus umbilical vein, Doppler, these are not going to be of much help because already baby is damaged by the time there is abnormality in these two. CPR less than 1 also there is a question mark about its utility in management of fetal growth restriction. Is fetal growth restriction an indication for cesarean section always? Can we do any treatment modalities? Can we add so that to improve the outcome in fetal diagnosed case of fetal growth restriction? So let us first see the second question. What is ineffective in fetal growth restriction management in the antenatal period is there is no role of plasma volume expanders, oxygen supplementation, heparin, aspirin, antihypertensives, as well as bed rest in management of fetal growth restriction because none of these interventions have shown in the studies to improve the overall perinatal outcome. That is, all these have been tried. There are so many randomized control trials, use of heparin, aspirin. Aspirin is their role is for prevention in the uh, high risk cases for preeclampsia. But otherwise, once you diagnose fetal growth restriction and then you start aspirin, it is not to be of any great help. So that is why these are all treatment modalities are said to be ineffective in management, unfortunately. Now, whenever we want to do the timely termination, we take a decision to terminate the pregnancy, then whether to give a trial for vaginal delivery or straight away go for cesarean section, it depends on fetal surveillance result. Normal non-stress test, normal BPP, vaginal delivery trial can be given, but whenever it is of FGR baby, careful intrapartum fetal monitoring is most important component as baby is more prone to develop hypoxia with uterine contractions. Oligohydramnios can lead to cord compression and that is why that risk will also be there. Now, whenever facilities are not inadequate, in utero transfer of the baby is indicated. That means rather than delivering the baby and then in a hurry transferring to a better neonatal perinatal facility is not indicated. In utero transfer is better. What are the possible neonatal outcomes in FGR? Suppose you see 10 patients. What are the various possibilities? It depends on type of small for gestational age baby. Once the baby delivers, we call it as small for gestational age by SCOG. Either baby can be small, but it will be, if it is constitutionally small, it will be a healthy baby. But when it is a compromised fetal growth restricted baby, hypoxia can be there, neonatal hypoxia. Meconium aspiration is another complication. Metabolic derangements are common, such as hypoglycemia, polycythemia, hyperviscosity. So all these complications are there in compromised fetal growth restricted fetus babies or small for gestational age babies, and not in constitutionally small babies. Even long-term neurological abnormalities such as learning defects, learning problems, all the disabilities, all these are seen more commonly in these compromised fetal growth restricted babies. Risk is more whenever the small for gestational age is less than fifth percentile. So by definition also post delivery also weight less than 10 percentile for that gestational age is the definition. Whenever the reduction in the weight is greater than fifth percentile, it is even less than fifth percentile, it is associated with a greater risk of all these complications. Now, this is another interesting hypothesis, and this is also a very favorite question. What is Barker hypothesis? And I hope all of you know it. I am just repeating it for the sake of completion. Barker in 1992 said that adult morbidity and mortality is related to fetal and infant health. Fetal growth restriction and macrosomia both affect adult health, can affect adult health adversely. FGR increases the risk of adult hypertension, type 2 diabetes mellitus, as well as atherosclerosis. This is Barker hypothesis. Now, what are the bad prognostic factors for FGR? Early onset FGR, static fetal growth on repeat ultrasonography, that estimated fetal weight or abdominal circumference is remaining same after 2 weeks. Then that is a definition of static fetal growth. Presence of associated oligohydramnios and Doppler abnormality, most important. Umbilical artery Doppler, middle cerebral artery, ductus venosus, and umbilical vein. These last two are associated with a very severe fetal hypoxia and bad perinatal outcome. What can be done for prevention of FGR? Low dose aspirin is not indicated in low risk group. It is to be given only in high risk group of preeclampsia. Should be started by 12 weeks, and maximum benefit is there whenever it is started at or below 16 weeks of the pregnancy. Usual dose is 150 milligram per day unless a woman is constitutionally very small, then the dose is 1 to 1.5 milligram per kg body weight. Aspirin is said to be more effective when it is given at night as compared to daytime ingestion. That is another tip for our patients to be followed in clinical practice as per RCOG 2024. Vitamin D, folic acid, there is a questionable role, but otherwise also RCOG is recommending vitamin D in all antenatal women with a dose of 10 microgram per day. It should be continued. Folic acid supplementation periconceptionally and especially in the first trimester should be given with a dose of 400 microgram per day. High risk group for preeclampsia, that is another question which can be asked, that in which woman you will give aspirin to prevent fetal growth restriction, prophylactically aspirin. If there is at least one of these conditions, prior preeclampsia, chronic hypertension, over diabetes, renal disease, autoimmune disorders such as APLA, SLE, antiphospholipid syndrome or SLE, and multifetal gestation. Any two or greater than two, nulliparity, age greater than 35, obesity, family history of preeclampsia, vulnerable socio-demographics, and prior low birth weight or FGR neonate. Thank you so much. I have taken help from Williams Obstetrics 2019 and RCOG guideline 2024 is available. This is a link I have given. Please go through that so that so many of the, if you have further doubts, then you can go through this. Topics you must read for a case of fetal growth restriction. Obstetrics is more challenging as compared to gynecology. That is my opinion, because obstetrics is so much interrelated that your practical examination viva can go in any direction irrespective of what the your basic case is. FGR will not be limited to FGR. You will be asked questions related to gestational age calculation, which I have included. Fetal Doppler, that video is available. Please go through that, and some part I have included in the present this video also. Antepartum fetal surveillance should be, you should be thorough in that for whenever you are dealing with a case of fetal growth restriction, and you are likely, sometimes you might be asked questions related to induction of labor also. Thank you once again.